probably. What's up, Drew? You
What's
guys
going
all,
on, homie?
everybody can see the screen, hopefully, right? All right, cool. All right, so I think somebody else is going to probably talk to you guys about full transplant, like a whole lecture on transplant. But I think a lot of the kind of you'll get like a general picture from the lung transplant lecture itself, like who gets transplanted, why they get transplanted, what are the outcomes like, and what are the major issues. But I think from a inpatient rounding perspective, one of the key things that you guys will see a lot, both as an inpatient and an outpatient that we deal with, is rejection. Rejection is still the one of the most common causes of people passing away from uh, a complication of their underlying lung transplant, regardless if it's a single or double organ. Um, and it evolves over time. And so, understanding or having at least some background in that will help you guys at least track what's going on during rounds and how we are making decisions, not necessarily making you experts in this topic, obviously, because you don't need to have expertise in this topic, but if you have a general idea of what we're doing or the way we think or why we think that, I think that will be meaningful during your guys' rotation. So I've given multiple different variants of this lecture, and this one is probably a good summary of the major key points of different sections, and I mean mostly of what I really want to kind of get you guys to remember is what is the interaction between the immune system of your recipient and the allograft or the transplanted organ, and then understanding uh, along the spectrum of time, how does rejection evolve or change, being in the acute setting or even in the hyperacute setting, all the way out to what ends up being very common in those who survive a significant amount of time. So after about 5 years, and I'll show you on a slide, almost 50% of people have uh, a form of chronic rejection. Within that realm of rejection, the severity of the rejection itself also varies, but it is present and it's ever present. And there are some caveats to it that are important really to understand. So this is kind of like a backbone list of the types of rejection that I'm going to highlight or talk about. The first one, hyperacute rejection, simply to put it to make it understandable, the recipient already is sensitized to the organ, meaning the recipient has antibodies against the organ that's being transplanted. And this can happen in people who have a very high sensitivity to foreign tissue. So think about people who get recurrent transfusions, people who already have had a transplant, and over time, their body, because of recurrent introduction of a foreign element, is developed a long-standing immunity to it, a humoral-based immunity to it, and we'll talk about that a little bit in the next few slides. And then acute cellular rejection, which is the upfront thing that we are trying to stop or that we're trying to balance with the risk of infection. And we know that acute cellular rejection is important because one, it's a leading cause of mortality early on. It's also a leading cause of development of chronic rejection in the future. So again, the same idea. The more times the immune system is activated, the more likely you are to develop a chronic form of rejection. It's just like repetition and anything else. The more you repeat a task, the better you are at doing it. And the more the immune system repeats attacking the allograft, the better it gets at it and eventually leads to failure of the organ. Now, that can go from the acute stage and develop a chronic form. And just like acute versus chronic inflammation, there are variations of the types of cells that are involved and the mechanisms behind this. And so that trajectory also is important to understand. And then development in the last few years, there's been a shift from trying to label everything a single type of chronic rejection, to kind of labeling chronic lung allograft dysfunction as an umbrella term that describes two of the most common types of chronic rejection, which is bronchiolitis obliterans syndrome and restrictive allograft syndrome, which we'll go into a little more detail. And then we've so far talked really about cellular immunity in the first three, these other two. And the very first one I mentioned, the humoral immune system being activated, or not the innate, or more likely the adaptive immune system being activated, and developing antibodies against the organ. If you have pre-made antibodies, you can develop hyperacute rejection as soon as the organ gets introduced to the body, or over time, like I said, repetitive damage to the organ, regardless of the cause, can instigate the immune system to recognize it as foreign, learn to label it as foreign, and then you develop what we call antibody-mediated rejection. Now, the next important thing is to understand the different types of treatment of rejection. And I think we kind of throw out all the names of the drugs during rounds. And so you guys will get used to the names, but what is each drug doing and why is it important in the grand scheme of things is also important. And then I don't like to talk about just what is old. I think it's always important to see where the field is now or where the field came from, and then talk about going on down the road, where can we get better? Ultimately, everything we want to do, again, is to stop this trajectory from acute cellular rejection all the way down to chronic rejection as long as possible, because we know that 50% of people who live to 5 years after their lung transplant are going to develop a form of chronic rejection. And if we can mitigate that, then we can have better success and a longer lasting organ. So now going into each detail a little bit more. Understanding immunity, there are two parts, right? So there's an adaptive immunity and an innate immunity. There are certain types of cells in our body that are responsible for each. So just like we say when we have an infection, neutrophils are the first kind of line of defense. Those cells go and attack whatever the invader may be, whether the invader is actually helpful or negative, as a negative impact. The immune system responds the same way. It recognizes foreign and attacks it. And over time, as the body encounters something that is foreign, it learns to recognize it and develop a more focused and less generalized approach to attacking that foreign object. And the same thing applies regardless of how the immunity is made. So ideally, I mean, if you want to break it down into what is naturally happening versus what we artificially create, we have immunoglobulins and immunization, both, right? We even have convalescent plasma nowadays, which has gotten really popular with COVID again, which it was used previously with Ebola and many other diseases. The idea being that if we could get pre-made antibodies to help the immune system recognize a foreign agent sooner or quicker and be more selective or more narrow of a response, then we can have a desired response. And so we know that with hepatitis B, we have IVIG. We also have IVIG that we use for people who have immunodeficiencies to help boost their immune system. These are all immunoglobulin-based therapies or antibody-based therapies that we are using. And then how do you induce the immune system to respond to a foreign agent? You can also immunize, and you can use something that generates antibodies. And so with all forms of vaccines, that's what we're trying to really do. And then natural immunity over time that becomes adaptive is how do you recognize different agents that you've been exposed to, whether that's something like the coronavirus or that's H. flu as a bacteria or a fungus. You can get sensitized to these agents, recognize them as foreign, and both your innate immunity and your adaptive immunity will learn to respond to that. And so I think that leaves a kind of a good framework for the next topic, is how does this all apply to transplant? So regardless of it's an infection and it's a negative impact or it's a positive impact by this foreign agent, in this case, a lung transplant, the immune system will respond the same. It just recognizes everything as foreign or not foreign. And now, again, you have two types of immune responses. You have the innate immune system. So these are kind of the soldiers on the ground that as soon as the organ gets in to the system, the body puts these cells, they come in through the circulation and respond appropriately as a foreign object. And these are all mediated by really the migration of immune cells from the bloodstream into the organ, the development of a milieu or a stimulus or a stimulating environment for the immune system to perpetuate the response. And then over time, you go from being on the right side of this, or I guess, yeah, for you guys also, left side of the graph or the illustration towards the right side. And some of these cells that are infiltrating this organ will go back and work with T cells and B cells, which are part of your adaptive immune system, to help develop a longer standing or a chronic form of response to the foreign object, whether that's antibody mediated or cellular mediated. You're trying to get T cells or B cells to recognize as foreign, label as foreign, and help direct all the soldiers on the ground to the right place to do the job. Now that brings up, so how do we stop this? Because we don't want this to happen. And so you're going to hear a lot of different names during rounds, depending on the stage that the patient is at. And so up front, you want to be very aggressive. What you're trying to do is almost hit a reset switch on the immune system so that you almost give it a little bit of a head start for the organ that has been taken out of your donor and being put in your recipient to actually successfully graft. You don't want the immune system to come in immediately and start destroying it as foreign. You want to give it some time to really form a connection and a successful medium for oxygen and gas exchange in the short term before you have to encounter these issues down the road. So here at Fairfax, we predominantly use induction therapy, and induction therapy is, again, that master reset switch. Traditionally, what we used to use was anti-thymocyte globulin. So we want to attack the T cells specifically to turn them off so that they can't direct the army to attack the organ. And that has kind of been transitioned over to a more selective regimen. And now we focus really on interleukin-2, which is one of the major cytokines that is used for communication between all these forms of cells. So our agent of choice here at Fairfax is actually basiliximab for induction therapy. Along with induction therapy, we start a regimen of 3 drugs typically. And the 3 drugs are used because they work on 3 different places in the cycle of a cell and in the DNA replication and perpetuation of the process. So the first group that you guys often and everybody knows are steroids. So corticosteroids work for this NF-kappa beta B, but it also you are trying to, again, target the lymphocytes of the immune system, that portion of the immune system that can be adaptive and learn to recognize the organ up front and direct the army into that organ to destroy it. So corticosteroids are one agent. Of course, they're also cause leukocytes, so other types of white blood cells, including neutrophils and eosinophils and other innate immune cells, to actually be not stimulated or block their stimulation. And so corticosteroids are a cornerstone. And then the other drugs that we use are cell cycle inhibitors. So here's the cell cycle during mitosis, and how do we stop them from perpetuating themselves. You can either kill all the cells off, or you can limit the cells that exist and keep them from overpopulating and causing trouble. And so that becomes one way of doing it. And then mTOR inhibitors also work also on the the cell cycle, but they are not used up front typically because they can cause, uh, because they work during mitosis when the graft is being connected back in and the connections are being made. You don't want to give an agent that can limit that. And so the mTOR inhibitors are a little bit stronger than the cell cycle inhibitors in affecting healing, so wound healing. So you don't want your airway anastomosis or your vascular anastomosis not to be successful. You really want those areas to the native vessel or the native airway to connect to the donor airway or the donor vessel successfully. Um, and then the kind of the last group here that we I haven't mentioned, but also work in the similar patterns are calcineurin inhibitors. Our drug of choice here is tacrolimus or Prograf, and that's because even though cyclosporin is older, it has a lot more side effects. And common side effects are high blood pressure, diabetes, and of course renal dysfunction. So Prograf has a lower incidence of this. It's just as effective. And it's a newer generation drug, so that we use that. But there are a lot of centers around the world, especially in nationalized healthcare systems, that use generic agents. So here you guys will see a lot of mycophenolate, which is a newer generation, better tolerated cell cycle inhibitor. You'll see us use far more sirolimus for that same reason. And then you'll also see us use more Prograf. But in national healthcare systems, you may see azathioprine, which is an older drug and more readily available and cost effective. And then similarly, cyclosporin instead of tacrolimus. And then similarly, basiliximab, being a newer agent, is a little bit more expensive. So some centers still use ATG as their induction agent. Now, like I said, we've kind of gone away from talking about just labeling everything as rejection to creating a bigger umbrella term to kind of classify this. So you can have acute lung allograft dysfunction. And the reason for this transition is also because there really is a strong connection between not just the immune system being activated specifically by the foreign organ. Sometimes activation of the immune system by another foreign agent, often viruses or bacteria, can stimulate the immune system to go into the organ and recognize it also as foreign and then go on to attack it. So lung allograft dysfunction can be both acute and chronic. And really this is important because you really want to recognize somebody up front. We know if it's like been 3 months, 4 months to a year, maybe 2 years, you're going to have a lot more acute cellular rejection. And we'll talk about what that looks like under a microscope and on a cellular basis versus chronic rejection. But that also becomes important to recognize that in the setting of an acute drop versus a long-standing drop or a sustained drop, when does it go from being really an acute loss of lung function or allograft function to being a chronic loss? And 3 weeks is the magic number. And here, another key point for you guys to understand is what is baseline. Baseline for lung function is determined after a certain period of time. Most people do not immediately get a new set of lungs and there you go, the lung is back to 100% of its effectiveness or of its function. Function actually improves over time as the graft really successfully grafts. And so the lung will actually increase its FVC and FEV1 over time. And about the 1 year to 18-month mark, you will usually get to your peak. There are people who have baseline lung allograft dysfunction and they never really achieve their real threshold or that baseline that you would expect them to. But if you take everybody who gets to their new baseline, that baseline is measured as the highest two values that they've ever been able to do on spirometry. So the average of those two highest values is their baseline. And a drop, a sustained drop for greater than 3 weeks below 90% of that baseline really means that there is a chronic form of lung allograft dysfunction. Now, it's also important to differentiate the causes, and we'll talk about the different things. So if you can find a specific cause before labeling a patient that truly they have chronic lung allograft dysfunction due to a form of chronic rejection, you want to look for other issues. And so this list of specific causes are there. Yes, infections, both viral or bacterial or fungal, and then You want to look at anatomic variation. So did the anastomosis stricture over time? So it was nice and patent early on during after the lung transplant, but over time it scarred up and it narrowed. And so now you have an obstructive form of lung disease, not because there's something wrong with the parenchyma, but actually something wrong with the large airway. And then, yes, there are certain diseases that can recur. So sarcoid or LAM have both been known to recur in the in the allograft even after a successful transplant years later. And then, can you have issues outside of the lung itself that are causing this decline in respiratory function? So, surgery, it is possible to damage permanently even the phrenic nerve. So you can have diaphragmatic dysfunction. You can develop pleural disease. So if you develop chronic effusions, or you can develop an effusion secondary to hemothorax, and that irritates the pleura, and then you get an effusion that recurs, or you again damage something structurally during surgery, and you can develop a chylothorax, which is due to leakage of chyle drainage or the fatty drainage from the GI tract that's coming up and being deposited into the vasculature in the thorax that gets ruptured and then leaks into the pleural space. And then one interesting thing that I always like to talk about is native lung hyperinflation. So this is really something that happens in single organ transplant and single lung transplants. So remember that compliance of a transplanted lung, a normal transplanted lung, is less compliant than a COPD lung, right? So a COPD lung keeps trapping air, and it will expand over time, right? And that's what emphysema does, and that's why they get all their classic changes. But if you have a single normal lung that is normal compliance, and you have a hyper compliant native lung versus a transplanted lung, the native lung may actually continue to expand. The chest is a limited space. So as that COPD lung actually inflates and hyperinflates, it will start to restrict the size of your allograft. So that will also affect your lung function. Now, if you have eliminated all specific causes, and now you have a sustained greater than or less than 80% of baseline for greater than 3 weeks, then now you have to start thinking about truly chronic rejection. So I can think that this diagram kind of helps you sort through some things when you're trying to figure out what is going on. Now to the specific types of rejection. So this is the classification of acute cellular rejection, and you kind of want to separate it into 3 different portions. So you really want to look at what is going on in the vascular bed, in the blood vessels inside of the allograft. You want to look at what's happening in the parenchyma, the actual tissue of the lung itself, the alveoli themselves, and then you want to look at what happens in the airways. In this case, specifically smaller airways, to really determine the level of rejection. So, and what you're looking for is how far out or how infiltrative is the immune system into the organ? Is it getting from the blood vessel, just staying in the blood vessel, or is it going from the blood vessel all the way into the lung parenchyma, into the alveoli, causing an immense immune reaction that leads to a very high grade of rejection? And so if you look at the classifications, you can see starts from normal lung parenchyma under the microscope, all the way to the point that you have diffuse perivascular, meaning the white blood cells have infiltrated around the blood vessel, within the interstitium that connects the blood vessel to the lung tissue, the airspace, and then actually within the airspace itself. And the cells here, again, you can see neutrophils are the cells that have been activated and are acutely going into the lung, just like they would for a pneumonia, right? So this is what a pneumonia would look like, or a cryptogenic organized pneumonia could look like at an early phase before it becomes organized. And so that is what the pathologist is looking for under a microscope when you take a biopsy of the lung. Now now we've talked about 2 of the compartments, the vascular space, and we've talked about the parenchyma, but what about the airway? And so you can get, similarly, blood vessels that are supplying the airways can also be a source for the immune system to enter into the airway and similarly cause an immune reaction or rejection. So generally, you will see A's and B's listed when we are describing acute cellular rejection based on this classification. The R's that you see in the grade is because of revised criteria, and this is what is showing you the revised criteria that we now use, that our pathologist, our lung pathologist, uses when he is grading the severity of rejection for acute cellular rejection. And so this is again, spectrum. Like I said, you can see that in A, just around the perivascular region, around the blood vessel, not around every single blood vessel, but only select blood vessels, there's an infiltrate over time that becomes more organized and actually extends out. And so slowly you go from a thin-walled interstitium to a thicker-walled interstitium, eventually leading to inflammation in some of the lung parenchyma, eventually diffusely throughout the parenchyma, developing a higher grade of cellular rejection. And similarly, if we look at airways, you can see again around between, in this case, you can see between the blood vessel and the airway there, in the structure, the interstitium that's holding that together, there's an infiltrate, and then slowly over time you see a lot more cellularity here that's almost completely obliterating any suggestion that there was an airway here, right? And then here, this GNH is going to be, this is what humoral immunity or antibody-mediated rejection really looks like. And what you're looking for is deposition of complement along the vessels. So you have floating antibodies that are marking the blood vessels of a foreign organ as foreign, and then you have activation of floating around complement that is trying to destroy the organ here. So I just showed you guys about biopsy, and this goes into kind of the future aspects of what lung allograft looks like. And this is one of the newer exciting technologies that we have there, which has become commercially available and was commercially available for kidney transplant and heart transplant, and is working its way into the lung transplant world. Now, this is something called donor-derived cell-free DNA. Now, we know that normally there's going to be a certain amount of cell turnover that's happening in the organ. As those cells turn over, they release their DNA. Some of that DNA seeps into the bloodstream, and we can measure the portion of cell-free DNA that's floating around in the bloodstream and determine whether it's from the donor or from the recipient. And you guys will see that we're using this also as a marker of allograft dysfunction. And here up front in the immediate phase, you can see that there's a range, but even if we use it, somewhere lands around in the post-operative period between 1% and 2%, and usually by 9 months or so, it has reached a nadir, a low level that it should be sustained at, because now you have no more kind of cellular death from the ischemic phase of taking the organ out of the body, exposing it to cold and to a lack of circulation, and then reattaching it and actually causing some reperfusion injury or even PGD, as you guys will hear about. But that cellular turnover, that cellular death is eventually washed out, and then the cell turnover becomes like a baseline, and you can see over time that you really do achieve a baseline. And during this baseline, if you know the patient usually runs around 0.5% to 0.25, a quarter to 0.5%, every time that number bumps up, then you know that there is something acutely happening. And similarly, you can see here, we know that the range should be somewhere around here. If we see above a certain threshold, then we can say that there is some allograft dysfunction. Now, the caveat with this, and this is where the next question comes up, do we need to design some sort of panel? Because you don't know what's causing the allograft dysfunction here. So if I go back a few slides, we talked about acute rejection, acute infection, or other causes for acute lung allograft dysfunction. What is causing the cells to increase turnover, you don't know. Is it the immune system coming in to reject the organ, or is it the immune system coming in to clear out an infection? You don't know. And so that will be kind of where things are headed, is can we figure out what is the underlying cause? We know that donor-derived cell-free DNA actually rises sooner than we can detect antibodies. So it becomes an early marker of dysfunction, but it's not clear exactly what it means yet, but it's something that's exciting. because maybe if we have a panel one day, we don't even need to biopsy. And there are a lot of centers that actually don't do surveillance biopsies. Here at Fairfax, we have, because of the pandemic, slowed down, but generally we did have a biopsy schedule that we checked every single person for. And this is important because you are taking biopsies with the forceps, which is a very tiny sample of an entire actual organ. So you may miss something. It's kind of like finding a needle in a haystack, that you may miss or actually find the rejection, or you may find the rejection but not at its greatest severity. So that was really the key things about acute cellular rejection that you guys should understand. Treatment, very straightforward, and you guys will see it again and again. We just blast everybody with steroids. Again, you're trying to reset the immune system. So if steroids don't work the first time around or the second time around, you may see that we actually um, kind of move to the next level. And the next level in this case would be something like induction therapy with ATG or with basiliximab. Now, going into chronic lung allograft dysfunction, which I think is a little bit more complicated because we actually, frankly, don't understand very much about it. We have a limited scope of what it means, why it develops, and really most of our understanding has started from other organ transplants, specifically bone marrow transplant and bronchiolitis obliterans syndrome. Uh, Really, that we've built on it. So, bronchiolitis obliterans syndrome really was the predominant type for a long time. But we are starting to understand that there are connections between different parts of the immune response, and even infection or chemical injury, like I listed here, that may play a role in the development of chronic rejection. Again, repetitive injury to the organ will stimulate the immune system regardless of what is causing the injury, whether that's CMV infection, or that is due to recurrent GERD or bile or acid aspiration, or antibody recognition of the, or B cell mediated or plasma cell mediated antibody mediated rejection of the organ, where the immune system keeps getting reintroduced to this foreign body and repetitively attacks it. So, like I said, unclear etiology, but these are some of the key ideas that we think about. And now, focusing on the subtypes, BOS, or bronchiolitis obliterans syndrome, you guys can see is a greater than 20% drop in the FEV1. This is a disease of the small distal airways, respiratory bronchiole specifically. If you look under pathology, you can see air trapping and bronchiectasis sometimes, as that inflammation extends up into the larger airways. And air trapping is typically a sign of small airway disease, as you guys know from like chronic hypersensitivity, pneumonitis, or other inhalation injuries, or even asthma and COPD in some extent. And then treatment, again, here is remove the agent that is precipitating this recurrent activation of the immune system. So you would need to avoid ACR. You need to avoid primary graft dysfunction even early on, because again, during that acute phase and reperfusion injury, that's a lot of injury that's happening to the organ, and a lot of leakage of organ contents that the recipient can be sensitized to. And then need to exclude antibody-mediated rejection. Can you treat it? Some of the ideas are, you'll see that almost all of our patients are on azithromycin as long as they can tolerate it. And azithromycin, you guys know from a lot of other diseases like CF or chronic Pseudomonas suppression, or even in COPD for chronic suppression of recurrent bouts or flares or exacerbations, is a key because of its anti-inflammatory effect. Here, anti-ATG again is important. You are again targeting the lymphocytes, T lymphocytes specifically, to prevent chronic destruction of small distal airways. And then here at Fairfax, years ago, I think like 2009, they did a study on montelukast, which they showed some benefit in preventing chronic rejection or BOS, probably because of some mediation between eosinophils and neutrophils that montelukast does, but not very clear what it's exactly doing. And then Extracorporeal photophoresis, we'll talk about on the next slide. Inhaled cyclosporin as well as another option, and then maybe even antifibrotic. So like maybe there is a role for pirfenidone, which has been studied, or other agents that can mediate the immune system or mediate the process where the immune reaction goes from healing back to normal tissue and deciding instead to heal to fibrotic tissue. And then here's just a classification on the bottom right, looking at the definition as it's changed over time. The severity of BOS is graded based on the FEV1. Now, again, BOS is a chronic form of rejection, patchy distribution. It's hard to catch on a biopsy. Again, like I said, finding a needle in the haystack, and then changes in classifications over time. Incidence is quite high, up to 50% at 5 years. And I'll show you a graph from the ISHLT database showing how prevalent it becomes over time. It really is described by this constrictive bronchiolitis by pathology, and then some of the same repetition that we talked about earlier. Looking at it under a microscope here, you can see that there's narrowing of the lumen of a smaller airway over time as you get organized inflammation. And then you can see during and inspiration how the lung fills up, and then the air trapping that's associated with small airway disease over time. And then this is interesting to see just different trajectories. This is an old paper, but you can see that some people develop BOS really quickly, and some people develop it very slowly over time. And these are just more pictures for you guys to see here, and again under a microscope, the obliteration of an airway, and then signs of air trapping and different forms of it. And then yes, bronchiectasis is possible over time. And I think this graph is key. We really are trying to prevent this from happening. Just like anything else in medicine, the longer you can prevent deterioration, the better your patient does. People who do develop BOS have a higher. It's a harbinger of bad things to come, and then mortality. The risk of mortality is very high even in a short period of time following the development. But you can see that people over time, obviously severity of the BOS may change depending on the grade, but it's almost ubiquitously present throughout when you get down to almost 20 years out from transplant. Now, some of the theoretical or beneficial things in research, and hopefully for the future, one is photophoresis. The idea is, again, you're trying to modulate a certain portion of the immune system to prevent rejection. In this case, we're using psoralins. So psoralins probably most famous from ancient Egypt for psoriasis. That you can use a psoralin to be activated by UV radiation, and UV light will activate the psoralin within a cell to cause DNA mutations that will lead to apoptosis of white blood cells or leukocytes, specifically lymphocytes. So similarly, they've used this for graft versus host disease. It's been shown here in the US and overseas in clinical trials as a potential way to stabilize lung disease. It doesn't necessarily reverse what's already obliterated, and I think that makes sense that once you get to a structure like this, to clear this fibrosis is very hard, or this milieu is very difficult to reopen this airway. Just like if you think about our IPF patients, whatever loss of lung function has occurred because of development of fibrosis, it's kind of there to stay, and your goal with therapy, again, is to prevent it from further progressing. So again, connecting back to our other aspects of ALD. And then cyclosporin, the idea with cyclosporin is, can you target the organ that you want the lymphocytes to be most suppressed in, versus giving an agent that is systemic and causes all of the other issues. I mean, if you think about development of chronic kidney dysfunction post-transplant on people who are on calcineurin inhibitors is quite high. And because of that, if you can get a targeted way of delivering the therapy, the better it is. Now, moving on to the next thing is restrictive allograft syndrome. And so we talked about an obliterative or obstructive form of chronic rejection. Now let's talk about the other side of the spectrum, because just like everything else in lung disease, either it's a restrictive process or it's an obstructive process. Now, this was underappreciated for a very, very long time, and this may be something that as we have gotten better at treating or controlling the immune system over time, the response of the immune system has evolved from affecting only the small distal airways to also affecting the parenchyma. And in this case, the disease is now extending from a different area. So in bronchiolitis obliterans syndrome, we're talking about small airways extending into the parenchyma and causing like the air trapping and the hyperinflation we see. But the immune system works along the entire interstitium. We know this from immune diseases like, or semi-posse immune diseases like sarcoid, right? So you get nodules in the interstitium, in intralobular and interlobular septum are where deposition of immune cells occur. As the drainage of the lymphatics occurs from the central portion of the lung into the hilar and mediastinal lymph nodes versus drainage in some of the parenchyma towards the pleura. So this process, to think about it, is kind of like almost the way you think about sarcoid, where there is a process occurring from the pleura into the parenchyma. And so you get a pleuroparenchymal process that you guys will see on the next couple of slides. But again, here, what you're looking for is a decline in lung function, whether that's defined by the vital capacity, the total lung capacity, or even by FEV1, where both your ratio is preserved, but you have a decline in lung function, just like we would see with our ILD patients. We know that this is actually developing more commonly now, or we are able to detect it better, so to say. So it's probably about 30% of patients. You can get a combination or mixed phenotype, of course. This carries a very poor prognosis. We don't have any therapies for it. And it really is, unfortunately, a death sentence at this point. Now, it's really recalcitrant to therapy. And we don't really understand why it occurs or how to target it. And so some people have tried, again, just like we use pirfenidone. It's been studied in bronchiolitis obliterans syndrome. Ofev and pirfenidone are also being studied as an antifibrotic pathway in the development of RAS as well. And so what does it look like? Very similar to pleuroparenchymal fibroelastosis. You really see large thickening of the pleura that's extending into the allograft. And you can see along the interstitium increased markings and this even fine fibrosis that you guys are used to seeing in patients with ILD that is now happening inside of the allograft. And I think, I mean, that kind of is the summary of that. There are limited ways for the immune system to respond to the foreign object or foreign body. And so whether that happens in the airway or happens in the parenchyma or happens in the lymphatic drainage in the interstitium or in the pleura, you will get certain types of phenotypes. Which phenotype occurs in each person, we don't have a way to predict that yet. But hopefully with time, as we understand the processes better, then we can target specific things. Now, the last thing that we'll talk about is antibody-mediated rejection. I got like maybe 5 minutes, which is perfect. So antibody-mediated rejection, we know this occurs in other organs as well. So almost everything that starts in kidney eventually spills over into all of the other organs. And AMR is nothing, it's not something else that's different. Again, so I showed you a slide earlier on with staining and fluorescence even, to really show you that complement fixation in the vasculature of the allograft is really how antibody-mediated rejection leads to chronic dysfunction and to acute dysfunction. If that process opens up the floodgates and the innate immune system, your neutrophils and eosinophils can extend into your parenchyma, then you can get something that looks like ACR under a microscope, but it's mediated in some aspect by antibodies that are formed against the donor. So AMR under a microscope can also be seen floating around in the bloodstream. And so what you're looking for is, like I said, complement fixation in the allograft. And so here you see lung biopsy that has C4D staining, meaning complement activation is being the complement system is being activated and depositing and leading to inflammation along the vasculature. You can see it grossly under lung histology, like we talked about. And then we really want to look for allograft dysfunction and exclude other causes for the picture that you're seeing. Now, the last column here is DSA, or donor-specific antibodies, and I'll show you a report and what it looks like over time. A donor-specific antibody means that if you take the HLA typing of the recipient and the donor, and you match them up, how many of them are common and how many of them are not common. And if they're not common, then in theory, the immune system will recognize that HLA subtype as foreign and develop antibodies potentially against it. So you have these are antibodies against class 1 or class 2 HLA. And so this is important because our treatment plans are slightly different between the two. So for class 1, we use something that is Velcade, that is more targeted towards plasma cells versus using CD28 targeting with rituximab for class 2 antibodies. And so class 1 ABC or class 2 DQ, DR, and DP, usually we see a lot more DR and DQ and mostly A and B, more so than C. So this is talking about donor-specific antibodies against HLA subtypes. But what about antibodies against non-HLA? The significance of this is unclear at the moment. Some people say that we need to treat it. Some people say we don't need to treat it. And so I've given you treatment as far as two agents that are used to destroy the cells that are producing these antibodies, but are not necessarily washing out the antibodies that are floating around already. So typically patients who have antibody-mediated rejection, they are given treatment with either of these two agents, steroids, and they also receive pheresis, plasmapheresis, where you're washing out floating antibodies. And there are two reasons for that. One is that you want to get the concentration of antibodies low enough that you can stimulate the body to wash them out of the organ that's being destroyed. And also the other reason is that you can, as you wash out antibodies, you can replace them with IVIG, which also has some immunoinhibitory aspect as well. So plasma cells in high levels of immunoglobulin will slow down their production. And so that's one way you can also help limit that. Now, what causes people to develop AMR? Really hard to say, similar to the other forms of rejection. It's probably repetitive destruction and damage to the organ, which leads to a lot of internal aspects of that foreign body to be exposed to the immune system and then sensitized over time. And then there's a question of when do you treat when there's a donor-specific antibody? Should you preemptively treat, or should you wait till you actually have a full kind of classification or certainty, a diagnostic certainty of antibody-mediated rejection by the presence of these multiple aspects in this table above? So looking at an example, this is from one of our patients. You can see that their HLA subtyping has been done, and you can see all the different types of class 1 and class 2 HLA categories and the presence of those subtypes amongst by their donor as well. So you can see there's a lot of potential mismatches. So here you can see it's similar, and then other areas you can see that there's differences. And so you can develop specific HLA subtypes to any of these. In this patient, you can see that in the report that they were able to find donor-specific antibody against DQ subtype 2. And if you really look back at the patient versus the recipient, you'll see that they don't have a DQ2, but their donor actually does. And so because of that, the antibody is developed over time, and that antibody is floating around. But a floating around antibody doesn't automatically mean it's going to do anything. And so you can look at the positivity of this in two aspects. you can see the actual concentration or the concentration that's going to be potentially cause a reaction in two ways. You can just use the actual level, or you can actually use and see if cells are destroyed when they are introduced to that environment. So if you have enough immunoglobulins that land on cells and are cytotoxic, then you know that there is a significance to this donor-specific antibody. Treating it yet is still kind of a question, but there's some evidence that there's benefit to that. Kind of probably for the same reasons that we've talked about. The minimization of repeated immune response will, in the long run, affect the survival of your allograft. And so you can see here, they've measured by immunofluorescence the level of the presence of antibody over time. There is a certain background noise that you would expect, and a cytotoxic level that you would expect based on that background. And you can see in this patient that there are donor-specific antibodies, but they have never crossed really that threshold to really be cytotoxic. And so similarly, you can see that is stated in the report as well. But probably there is going to be a data down the road. Like I said, with the donor-derived cell-free DNA, we can see that even though you have DSAs or donor-specific antibodies, you can catch allograft dysfunction pretty early on, maybe even earlier than the presence of antibody at a level that you can detect it, or that it becomes really toxic to the cells itself. So I think that's the last slide for this presentation. Does anybody have any questions? I know there's a lot of different aspects, but hopefully it gives you at least some definitions or terms for you guys to understand where we're coming from during rounds on the floor or in clinic. Okay, cool. Thank you guys for listening.
Thank you.
Thank you.
Thank you, Dr. Ahmed. Tomorrow I'm presenting a journal club about donor-specific antibody, and I will piggyback on your last slide if it's okay.
Perfect. It works out well for you.
All right. Thank you so much.
You're welcome. See you guys later.